my first talk was how to choose a multifocal IL for patient. Now the second talk will be on how to choose a patient for multifocal IL, how you are going to match the patient. So what are the important preoperative pers? What are the ideal patient? Basic necessities are same, like 6/9 or better best corrected potential vision. There should be there should be possibility of binocular implantation. No one-eyed patient, no squint patient. Healthy, many times we miss this, squint. Patient has squint, you feel patient has both the eyes, but patient is using one eye at a time. So he is actually one-eyed. No corneal, vitreous, retinal, neuroophthalmic, neurological problems that may affect vision or adaptation. So going into details, as we learn in our, when we are going for MD, we start from history and demographics. So age, I do not prefer multifocals above 75 years of age, but decision is taken based on general ocular health and patient's requirement. I do not prefer multifocal below 40 years of age unless bilateral implantation is planned. Because these are the patients who have never experienced presbyopia and they may not understand the problems associated with presbyopia and never be happy with these IOLs. Patient less than 25, they are not clear about their occupation, how they are going to do later, so I generally avoid unless they have a clear idea of their occupation. Gender, the talk is incomplete without the housewife and house husband theory. But gender in general determines the hobbies and overall working distances, so that has to be taken into account, but we have to individually each and every person. Occupation, I think it is the single most important factor that will determine whether you are going to go for multifocal IL or not, because almost all of us, 10 to 12 hours of our day are going, are spending in our occupation. So occupational drivers, long night drivers who drive as a hobby are strict no. You have to look at the different distances which I have already discussed and choose the IOL accordingly. Farmers are good candidates because they hardly use any glasses when they are working in the field because there is a lot of sweating in India. Usual time for which they are going to do the near and intermediate vision task, because if the patient is going to use the near and intermediate vision occasionally, I think they are the best candidates. If for example a person is going to use laptop or desktop for 10, 12 hours, I think I usually tell them that, see, if you want to use it for such a long time and if you want to read finer prints, I think you may need glasses at times, because their eyes may get fatigued over time. Doctors, it depends on specialty. Generally, they tend to do well in non-surgical, if they are in the non-surgical faculty. But usually surgeons do not do well because of the loss of contrast, which is associated with multifocals. Now, avoid patients with occupations where patients generally are suspicious of all things, hypercritical, also feel they know few things about surgery better than doctors like lawyers and politicians, these kind of patients. Also the hypercritical patient, my general idea of hypercritical patient is that once he comes back from counselor and asks me the same question twice, I generally start avoiding this patient. I tell them, I think monofocal is a better choice for you. Going into details of systemic disease, I think most common patient that we see are diabetic patients, and I think unless the patient's macula is affected, I would go for multifocal IOL. Avoid patients with neurological and psychiatric problems, because I have seen that they have problem with neuroadaptation, even if they have good fields. Avoid generally debilitated patients because this is not really required for them. Now, one of the most important things which we may miss out is the fellow eye. How is the fellow eye? If the fellow eye has no cataract, you can never match that vision with any imported or any good or any brilliant, any trifocal IL. So he is always going to feel the difference between the good eye and the operated eye, and he is going to be the one, apart from ophthalmologist, who is always going to do the alternate cover test. This eye, this eye, this eye, this eye. So always avoid these patients. Also, if the other eye is absolutely emmetropic, even if he is in presbyopic age group, and if he has -1 to -2.5 spherical error in the other eye, again the same thing, he will always compare with the other eye. So you have to explain these things to the patient very much in detail before the surgery, that see, your natural, the patient, the eye with the natural lens is going to behave much better for that particular distance than your operated eye. Also the squint and amblyopic eye, you have to just avoid. Preoperative refractive status is very important. Those who have significant refractive error but never used glasses before are excellent candidates. Myopia, high myopia more than -5 with good potential vision are good candidates. I have not personally experienced any effect of angle kappa or alpha. Low myopia needs proper counseling before going for surgery. And hyperopes in general are very good candidates. Now, next thing is the astigmatism. I think higher degrees of cylinder preoperatively are good candidates if you are planning a toric multifocal. But if there is a low degree of astigmatism, I am generally aggressive for treating astigmatism for multifocal patient. I treat all the patients with the rule astigmatism more than 1 diopter and against the rule more than 0.75 diopter, either with LRI or with toric multifocal, because astigmatism has to be corrected for having good results. Now, cataract status, in cases of mature intumescent cataract, it's not a contraindication at all, but patient has to be explained that we cannot tell about what is the potential vision is going to be in that particular eye. The patients who have got cataract since long time, these are excellent candidates, because either these patients are afraid of surgery or they are not bothered about by poor vision. These are the typical patient who will say, doctor, I can see everything very clearly, and you say, sir, you are talking to your son, I am standing here. So these are the typical patients who are not bothered about vision. These are very good candidates for these lenses. Posterior subcapsular cataract, because it stays for very long time and patients are used to the glares which are much more obnoxious and troublesome than the multifocal IOLs. So they are already used to these glares, so these are good candidates. Posterior polar, I think keep 3-piece multifocal always ready, but otherwise they are good candidates for doing multifocals, not an issue. Now, pseudo-exfoliation and weak zonules, I think it is a surgeon's decision. He has to think about the lens centration, whether there is going to be any problem in the future. If he feels that the zonules are not good enough, I think best to avoid these multifocal in these patients. Post-traumatic cataract, many times the problem is that these are generally unilateral, and you have to assess the anterior and posterior capsular status properly. Subluxation, the lens should be avoided. You have to think about the potential vision also in such patients. Now, potential vision, you have to do all these things. I do retinosity of all my patients irrespective of multifocal or monofocal. Most important thing which we miss out is pinhole vision. Very, very, very important, and I think surgeons should do that themselves, because many times the pinhole vision in dilated status is much better indicator of the potential vision. Fields topography also be used as per requirement. Most important tips about counseling, and these are very important. I have got the checklist for my counselors where everything is written, where he explains the patient chances of requiring glasses, glares, halos, adaptation period, why, and also those patients where multifocals have not indicated, why it is not indicated in that patient, and also prognosis is known to the patient before surgery, and patient and counselor must sign that checklist before giving appointment for surgery. And in general, not for multifocals, but in general, the prognosis I have decided on 4 lines, which is explained to the counselor, and a counselor explains to the patient. Good, guarded, very guarded, and unknown. So every patient knows while taking the appointment, these are the categories I am into. So counseling should be there. It should not be counseling. So I have told my counselor it should be always truth and nothing but the truth. Explain every patient that he may need glasses after multifocal implantation, because everything is dependent on the best machines that we have, but still it has ±5% error. And counselor should have very good knowledge of most of the ocular diseases, why that particular patient is not fit for multifocal. So never sell multifocal lenses, let the patient choose. Just like practice takes a time to build up, multifocal lens practice will also take time. Explain multifocals even to patient not suitable for it briefly, and telling them why they are not suitable. The advantage is that he doesn't feel later that he was not given a choice, and second, he becomes aware of existence of such lens, so he may tell his relatives that these kind of lenses appear. So thank you so much.